I tried to find him yesterday evening, but he wasn't here. This.
Don't know what it is. I don't think it was Spanish. I got the machine.
Is there a spare glass for me, maybe?
Yeah.
Great.
I think I took yours. Yeah, sorry.
No, that's already used, I think.
Okay.
Is Tanya going to introduce you? Is she going to start the session?
No, she said no, so I have to do the whole job.
Okay.
Tell me.
Getting a presenter from Ukraine at the very end.
No.
Odessa.
From?
Ukraine,
Yeah.
Odessa.
Kiev? Odessa?
Odessa.
Okay.
He will introduce himself. Obviously, we got a stand-in last minute. Our original presenter had to cancel because of the rockets. And we have now another representative from Odessa.
So the person from Kiev consult, and this is somebody from Odessa. Okay. What's her name? What's her name?
And then we need to start because Nant is already on.
Okay. Okay. So we finish at what time?
We have until 4:15.
3:15.
4:15.
4:15. Okay.
And
Thank
Nant
you.
is ready now, so he's
Okay. Could you write me your name here? Yes. Thank you. Good afternoon, everybody. I hope you're doing well. Thank you for being here and attending this session. Thank you, IAPAC and Tanya Dishfred for the invitation. And thank you to the whole organization team. You did a tremendous job organizing this conference. And we know how hard this job can be, so thank you indeed. My name is Elodie Aina. I'm from AIDS-free Paris, France, and I'm delighted to be here with you and that we will spend some time together, and I'll be moderating this session. But as an introduction, if you allow me, I would like to say some few words in Spanish in order to honor our host. Queridas y queridos participantes, miembros del movimiento Fast Track Cities, muchas gracias por la organización de esta conferencia que nos va a permitir compartir experiencias locales. Y de nuevo, gracias por hospedarnos en esta hermosa y cariñosa ciudad. It's short, I'm sorry. I pretty much put all the Spanish words I remember from school in that introduction. But I really wanted to thank you for your hospitality. Yesterday we've been in this fabulous historical site at Alcázar. It was very beautiful, and all the streets around. And so be sure we're very happy to be your guest here. So what about this session? This session is about city case studies in Europe. So how those cases have been selected. They've been specifically selected either because they had good results, it means they performed well with the 95 targets or the stigma indicators. Either they've been particularly innovative in their approach. So in order to highlight progresses made across the Fast Track Cities network and facilitate the sharing of best practices to attain the goals, objectives, and targets to which all Fast Track Cities are committed, we will focus on 5 cases in this session. First, we will start by Nantes. Nantes is a city of France. I know it's quite rude to start by France when you are French, but I swear I did not make this program. I'm just here to present it. And don't believe people who said that we are pretentious. And after Nantes, France, we'll focus on Cardiff and Vale in the Wales, UK. Afterwards, we'll listen to the case of Amsterdam, Netherlands. And we'll go on with Prague, Czech Republic, who will be virtual. We have a new guest actually Initially, our friends from Kyiv in Ukraine were supposed to intervene today, but as the situation that you know has been very difficult there, finally we have our friend from Odessa who will intervene. And then we'll finish by our dear host from Sevilla, Spain. As we will spend something like an hour and a half together, we will have quite some time to take questions after the different interventions. So I will kindly ask the different speakers to try to respect the rule of the 10-minute rule. I know it's hard. I've been in your shoes. We always want to share as much thing as possible, but it would be great if this session could be as interactive as possible. So let me introduce you to our first guest from Nantes, who is virtual. So Nantes is a city of France. It's located near the Atlantic Ocean that we call West Coast, even though we don't have good rap music there. And it's an NGO called Nantes Zero New Viral Infection. The speakers will be Jérôme Gournet, who is an hepatologist and the president of Nantes Zero New Viral Infection, and as well as Christophe Jouin, who is the city councillor of Nantes in charge of public health and precariousness. So Jérôme and Christophe, you've got the mic. La parole est à vous.
So, can you hear me? So,
So thank you very much, Jérôme, for this great initiative. We are looking forward to discover the results next year. Is there any question in the room for Jérôme? Don't be shy. Okay, I have a question, especially about the HIV self-testing program, about the positivity rate. As the people are self-testing, how will you evaluate the number of people who are HIV positive among the tested population?
Well, it's a very good question, and it's very hard to answer this question right now. I don't know exactly, maybe between 1 to 3% of patients, of people, I don't know exactly. And you know, we don't have that much data regarding this kind of test program, and so we don't know currently. But we expect to find, yes, between 1 to 3%.
And for both programs, either the hepatitis program or the HIV program, how will you make sure that the people who discover that they are infected will be treated?
So for the HIV program, we have all the non-profit organizations, the community, which are going to follow these patients and to try to drive them into the care if necessary. For hepatitis C interventions, we have experience in France, and there is other experience in other countries of Europe. And we know that it works well because the issue is to do all the procedure very shortly, on a 2 hours period. So once the people is there, we can make all the process, all the evaluation process, and to prescribe the treatment if necessary, and then to accompany them, to follow them, to support them to go through the treatment, to be eradicated of hepatitis C infections. But we have experience in France. There is also experience in Barcelona, also experience in Scotland. We know that this short procedure is very effective.
Okay, thank you very much for your answer, Jérôme, and thank you for your intervention. So let's go on with the next case. The next case is Cardiff and Vale, Wales, in the UK. We're about to hear Dr. Darren Cousins. Darren is a consultant in sexual health and HIV at Cardiff Royal Infirmary. He has an interest in developing sexual health services related to men who have sex with men, with the aim of making healthcare more accessible to those who need it, with the background of austerity, PrEP, and vaccination challenges. He also sits on the clinical effectiveness group of the British Association of Sexual Health and HIV, and he is a member of the Wales HIV Action Plan Working Group. Quite a resume, yeah? So please, Darren,
okay,
we're listening to you.
Thanks very much. So, yeah, I'm here from Cardiff and Vale to present some information about our city update and also getting to a national action plan, but also actually making it happen. So thank you for the very kind introduction, and I'm part of the Fast Track Cardiff and Vale network. Okay, so I really put this up just for background because not everyone will necessarily know our local ecosystem where we sit. So Wales is a country within the United Kingdom, but although we're a full part of the UK, we have a devolved health system. So we have our own Welsh Senedd, the Welsh Parliament, and we have a Welsh Government that is very different in colour in terms of political affiliations to you would see in other parts of the UK. So the Welsh Government is unashamedly socialist. It's not really a word that's said outside of Wales, but you know, time after time, Wales elects governments down the socialist path, which is very different to what happens in other parts of the UK and increasingly so in Europe. We have strong support across this political spectrum in Wales for the work that we're doing, and also to make the point that we have a strong LGBT representation whatever that was. Okay, so, and our partners that we have within Fast Track Cardiff and Vale are just down in the bottom left. So crucially for us, we include Cardiff University as a key partner, both because we're a student city and we have lots of students in our city, but also through the research and evaluation frameworks, we've used them a lot, and they've been a good part of this. No, never mind. I don't think it's me. Okay, and the pie analogy is really to suggest that health funding and almost all HIV and sexual health work in Wales is through health. It is not through local authority. The funding to Wales is very straightforward. It is a pie mentality. A set of money goes to the Welsh Government, a proportion of that goes to health, and a proportion of that geographically goes to Cardiff and Vale, and then it is a bun fight. So whoever wants funding for HIV sexual health services has to compete against renal transplant, paediatric oncology, and all the rest. So we don't have the purchase of provider framework that has in other parts of the UK and in Europe, but actually that has pros and it has cons. Okay, so we have now a HIV action plan for Wales, published by the Welsh Government, with the aim of improving quality of life and tackling stigma associated with the virus. The action plan will tie to 2026, which is the next Parliament cycle. And then the journey. So how did we get there? So Terence Higgins Trust, the HIV charity that works across the UK, and Fast Track Cardiff and Vale set a manifesto pledge to the parties pre-election. So all the politicians were sent basically a crib sheet of what we want to happen within the HIV sector. Labour, so the left-wing party, agreed to include the action plan in their top 100 must-do priorities. Plaid Cymru, the Welsh Nationalist, pledged to end HIV transmission by 2026, which was a little bit optimistic considering the election was 2021, but you know, the support is there. And even the Conservatives, who historically have potentially been less helpful in Wales, sent supported letters, but then did forget to put it in their manifesto, but actually have given us good support since the elections. So Labour won the election with subsequent cooperation pact with Plaid Cymru. So politician-wise, we're doing fine. So there's a planning mechanism where we have in existence a National Sexual Health Programme Board, which is a wide range of interests across government, NHS, Fast Track and THT. HIV Action Plan subgroup, which was key people out of this, including the civil servants, and also organisations like Stonewall, the LGBTQI charity, and also we then had working parties on different themes, and that's where we brought in other organisations such as Prepster, people living with HIV who were present throughout, and Cardiff University research team. It was quite a challenge to get people living with HIV involved from the start because they weren't being let in, and there was very much a feeling that we'll involve people afterwards, and actually we very much feel that we co-develop services together from the start, and Fast Track was a really good mechanism for getting that kind of thing in place. So the initial process involved quite initial ad hoc meetings with no clear budget attached. Key stakeholders and experts were added as identified, so it seemed a little bit organic. There was an assumption of very quick outcomes. Can you do a stigma survey? Let's have it by next week. You know, seeing the work that was done this morning in South Africa and in other parts of the world, these are quite meaty projects that need a bit of thinking through. We developed the working parties, and although some areas of the work, such as data and procurement, were reserved for people internally within certain organisations, and there was some investment from underspend on pilots and research during the development process, not least of all COVID, you know, and then monkeypox through a few spanners in the works along the way. So we had significant barriers. So we had virtually no NGO sector left in Wales. We have people who used to work for NGOs around who've been incredibly helpful, but no actual NGO sector left. There was no funded formal HIV support outside of the clinical services, so outside of health. And it is worth saying that there was a low Welsh engagement in and awareness of pan-UK services such as peer support. There was no local awareness campaign for almost 15 years and very little local prevention work. I moved from an English service and was really horrified to see what was out there or what wasn't out there. There's substantial postcode lotteries between health boards, for example on PrEP access. We're only a country of 3 million people, but the whole middle of the country is basically hills and mountain, and if you're in a rural area, you particularly struggle for access to some of the services, as you would for any part of health. The data was pretty poor, so the clinical IT systems where they were in place were all different and couldn't talk to each other, which is, I know is an issue elsewhere, but for us, with a small population, it's not where we want it to be. And there's a high level of HIV late diagnosis, but a low prevalence. So we felt that marginalised groups lost out twice because you didn't have a good promotion agenda, and then they weren't tested until late in particular. But also some advantages. So since COVID started, we had a successful online national postal HIV testing system. That's free, that is age independent, and that is geography independent. So anywhere in Wales you can access that. What we know from our clinic changes during lockdown is we demonstrated options for better access. So we have an instant access PrEP virtual walk-in service in Cardiff, hosted by some national video platforms. There's an appetite for reform of data in other systems. We're desperate to get on and do this. And Fast Track Cardiff and Vale and its pilots were really helpful in demonstrating the viability of things like GP-assisted testing, HIV testing week promotion, social media support, advocacy networks. We have a single centralised lab network and language for things like viral loads and HIV tests that helps with surveillance, so you're not cross-referencing. And then one of the benefits of very centralised services such as the Welsh Gender Service, the gender affirming service for Wales, is there is very much a once for Wales mindset. You do this in Cardiff, you do it in Swansea, you do it in Newport, you do it in North. It gets raised up together, and I think there are benefits for that. And as I said, we had very highly supportive and informed politicians in power. So the key recommendations included prevention, testing, clinical care, living well, and stigma, which kind of fits with what national plans happen in other jurisdictions. Okay. I think in addition to this, there's been a commitment to surveillance and evaluation, so in particular a pan-Wales case management system so that we appropriately survey what's coming through the clinical services and the health services, and with evaluations through our university partners and increased scrutiny of late diagnosis and increased highlighting there. So alongside this, there was support for expansion of the fast tracks and the creation of a Fast Track Wales network alongside our own HIV advocacy network. And then timetable-wise, the HIV Action Plan has been out for consultation, and that is currently processing. I put an exclamation mark because it was originally due to be published in September 2022. It's going to be a few months later, but part of that is actually making sure that whatever is published will be funded. Some bits of funding are agreed, some bits are not. The various bits up for discussion. And then implementation. But actually what's happened in the start of this process. So there's having a plan, but there's actually what happens in creating a plan. And I think it's fair to say that the genie is out of the bottle. So by having these conversations, a lot of conversations are happening, particularly outside of sexual health, infectious diseases, HIV services, to the point where, for my health board for Cardiff and Vale, the response to the consultation was actually written outside of sexual health services. So normally these things get sent to us, what do you think? And actually they were very keen to put their own take on it as a whole health system, which I think is to be valued. There's some individualised promotional programmes looking at HIV stigma in geographical areas rather than relying on a national agency or increasingly fast-track cities and the volunteer network that we have. There's desire to build a case management system from the ground up to meet user requirements rather than buying something off the peg that may not do exactly that you want, what exactly you would want it to do. There's a coalescing of the advocacy networks. People start to know each other. It is sometimes the same people in meetings, and that's good because you start to get these links together. And what we know is even outside of specific testing, there is increased uptake of HIV testing, particularly through the online services, even outside of the pilots. And there's been various recent service redesigns in sexual health. Just to finish, one example of what we've done is texting for testing, which is a GP offer of a HIV test sent to all residents in Cardiff and Vale. So it might not come up very well on the large screen, but you'll get a text from your GP to say, GP support HIV testing, follow this link for a free HIV online test delivered to your door. We did it as a pilot in one part of Cardiff and found a young man with a CD4 of 180 at baseline who is pretty fit and well. So this mass population screening, we're looking to see if this works. It is hard work, we really want it to come from the GP. We don't want it to come from a slightly anonymous public health body or somebody else. And convincing GPs without huge amounts of money attached to it is quite a challenge. I've certainly started to go grey because of it. But as things stand, we're about to go live with the second third of Cardiff and Vale. We've already done a first third, the kind of easy ones. And we've been able to do that with the Fast Track network and the support from the local authorities, the support of local head teachers in schools, the media announcements, there's various other bits that have gone behind that. Some areas are keener to engage with others. I think that's fair to say, and there are other challenges in primary care. So there's various contract negotiations happening for what is part of general medical services in GP contracts in Wales, as there is elsewhere, and it's competing priorities. You know, do they focus on diabetes, HIV testing? What are they going to give their time to do, let alone COVID and the backlog? And that takes us to the end. So just the final mural that we've got. So we're starting to see visible signs on the streets of Cardiff that HIV is there to be talked about. So these are billboards in Cardiff Bay, around the corner from the Welsh Parliament, about HIV awareness. Don't guess, take a test. Wyt yn gwybod, do you know? And these are some of our amazing people living with HIV that we used as models for this. So thank you very much.
Thank you, Darren. Thank you, Darren. That was very impressive. Is there any question for Darren? Yes, please. Oh, I guess.
Thanks.
I don't know how it works.
Yes, I actually have three. I actually have three questions for you. First of all, what is meant by ending HIV by 2026? Is it zero? Is it
Yeah. This was a
formula?
political party that got a bit carried away. So put something in their manifesto that we said you would never be able to do in practice. So it was just highlighting that different political parties took it up with different enthusiasm. So it was over-enthusiasm rather than government policy.
So just to add to that, then is there from your perspective, is there a concrete target?
Yes, so it's end new transmissions of HIV by 2030.
I'm sorry, say it again.
Ending new transmissions of HIV by 2030.
All transmission.
Yeah.
Okay. And my second question is, what accounts for the high number of late diagnoses from your perspective?
Yeah, I think the challenge being from an area that compared to certainly, larger cities, we're seen as low prevalence. So HIV has historically dropped off the differential diagnosis. So we know that when people were presenting with things like shingles, they weren't being offered a HIV test. It was, I think, fair to say in our service, and certainly before COVID, it was difficult to get a HIV test. So we have this wonderful online, free, age, whatever, access to HIV testing. Prior to COVID, to get a HIV test, realistically, you had to queue up for hours in a service, such as ours in Cardiff. We didn't have an alternative way of doing testing. So I think there was, as a gay man moving from the English setup to the Welsh setup, I was very surprised about the low literacy in the MSM, in the gay and bisexual MSM communities in Cardiff and Vale, amongst friends, amongst people I met, amongst patients I saw. Other places I've lived and worked, it was very much, we get tested every 3 to 6 months. That wasn't the case before. So there's multiple issues that it could be, but I'm not sure we've fully fleshed them out, but we're getting there.
So my last question is that the only social determinant that I saw mentioned in your slides was stigma. What are the other social determinants that are either putting people at risk or inhibiting treatment, and what, if anything, is being done to address them?
Oh, I mean, this is just a small proportion of the stuff, of the work that we're doing in Fast Track. So there's, there's country of origin, there's migration status, there's poverty, there's plenty of other things that we're working on as well, collectively as a group. So that's just a snapshot. So there's plenty more we're doing.
Okay, thank you very much. Sorry, I have to stop the question here because we have other presentations, but Darren will be free, I guess, after the session to answer your questions. So now let's focus on Amsterdam, Netherlands, with Elske Hoenenborg. Do I pronounce it correctly? Okay. So she will tell us about a very innovative study about intention to use long-action HIV PrEP among MSM.
No, that's not correct.
Oh,
No.
I'm sorry.
That's-
I got the wrong information.
Yes, sorry, that's later in the oral abstract session.
Okay.
So today it's about Amsterdam.
Okay. So please, we are listening to you.
Thank you so much. I'm sorry, I've catched sort of a cold. It's not corona, but it's still a bit annoying, so I apologize for that. And I'm here from Amsterdam, the Netherlands, to present the Amsterdam case study. Thanks to the organizing committee to invite us, and also thank you very much for the Circle of Excellence that Amsterdam received yesterday for our proceedings in stopping HIV and viral hepatitis. This is the outline of my talk. After speaking a little bit about the epidemic in Amsterdam, I will mainly focus on innovations that we are implementing in Amsterdam to get to 0 new HIV infections. Some data from Amsterdam and the Netherlands. Here you see the number of new HIV diagnoses over time. In Amsterdam, the red line, and in the Netherlands, the blue line. There's 2 lines. The lower line is for infections that are locally acquired or diagnosed after people arrived in the Netherlands. And the other line, it also includes people who already were living with HIV and then moved to the Netherlands. And what you can see is a really nice drop in number of new diagnoses. If we dive in a bit more on the Amsterdam data, you can see here the new diagnosis for men who have sex with men on the left, and MSM and migrants on the right. And for both groups, you can see quite nice drops. This is where the PrEP program started in 2019. And well, it seems to have accelerated the decrease even a bit more. Other way to look at epidemics is through the continuum of care. This is the continuum of care for Amsterdam for the total population. And you can see that only 14%, about 900 individuals, are living with HIV, but have not yet reached an undetectable viral load. Bless you. And then the numbers are 95, 94, 95. So that's really something that we're proud of. And if we focus a bit more only on MSM, only 11%, about 500 individuals are living with HIV, but have not yet reached an undetectable viral load. And the metrics are 97, 95, 96. So how did we get there, and how are we proceeding to reach 0 new transmissions? Well, we're lucky in Amsterdam to have the H team. It started in 2013, and it's basically a platform for innovation. We are with the H team has a broad representation of partners from care, hospitals, GPs, public health service, community organizations, NGOs, and also data surveillance organizations. And together, it really gives a lot of think force, and we're coming up with innovations. And I will present 4 innovations to you. The first is increasing awareness for acute HIV, rapid diagnostics and linkage to care within 24 hours. We do this through a website, doihavehiv.nl, but then in Dutch, happygive.nl. And the website focuses on knowledge and recognition of symptoms of acute HIV. It also includes a symptom checker. And if you complete all the questions in the symptom checker, you get a personalized advice, which is either go to get a test for acute HIV or, we don't think you have acute HIV, but it's still a good idea to get tested every now and then for HIV. You're referred to a rapid diagnostic trajectory, and if the test is positive, you're immediately referred to a hospital and started. And here are some of the outcomes of this trajectory. On the left, you can see that we're finding more early and acute infections after implementation of this trajectory. You can see it by the red colors in the graph. And on the right side, you can see that persons who are diagnosed through this acute HIV trajectory are reaching viral suppression earlier than MSM who have been diagnosed through regular processes. So that's a good thing. The second innovation is online PrEP provision in the Easy PrEP project. The Easy PrEP project is a randomized controlled non-inferiority trial. It consists mainly of two pillars. One is online PrEP provision, and the other one is standard PrEP in clinic. And in both of these pillars, we further randomize participants to 3-monthly or 6-monthly HIV and STI testing. And we do that because we are investigating whether we can make the PrEP provision less costly and increase capacity. All participants also, as you see on the left, have the access to an app with a diary and access to online PrEP services. Innovation 3 is reaching out to the transgender population. On the right, you can see the team that we're working on, and on the left, you can see the prize that this initiative received earlier this year in Amsterdam. So why are we doing this? Well, here you can see some of our data from the Center of Sexual Health in Amsterdam, 2017 up to 2021. And you can see in the blue line that number of new HIV diagnoses are decreasing in men who have sex with men. But in the orange line, you can see that diagnoses among transgender persons are not decreasing and even increasing a bit. And on the right, you can see it on a proportional scale, and you can see that among all new HIV diagnoses, the proportion of trans people is increasing. So this really urged us to do something and to come up with a program for trans persons. And we are doing this as public health service, GGD Amsterdam, together with a community organization, Trans United Europe. And we're really started a co-led clinic. We're really doing this together. And we know that trans people in Amsterdam are not easily reached with just sexual health services, because the demand is really, among others, for hormonal support and psychosocial support. So that's the integrated package that we're offering together, trans persons from the community and professionals from the public health service. It's provided for the trans and gender diverse community who experience barriers to access regular care, so that's asylum seekers, people who are homeless, people who are active as a sex worker, or those with a migrant background. And tomorrow, my colleague Camille Welling, who's also here present with us, will tell a bit more about this clinic in the urban and community leadership session. So be there if you want to hear more. The fourth innovation is information meetings for LGBTIQ+ newcomers in a gay club in Amsterdam. We call it the sexy side of the Netherlands. And it's really nice. It's a nice gay club. There are performances by drag queens, there's music, there's food, and there's a lot of people who can provide information, who can test for STI, who can vaccinate for hepatitis B. So that's a very nice and effective way of giving information to this new coming group. Well, I also want to tell you about one innovation in the hepatitis C field. This poster was presented by Chris Hagen, our colleague, yesterday in the poster presentation, and it's about interventions aimed at reducing HCV reinfection in MSM, the ice cream study. And it's basically two interventions that we're testing. One is in the middle, it's HCV RNA self-sampling tests that are handed out to people. And the other intervention is on the right, it's about an online behavioral intervention. The study is still including recruiting, so we don't have outcomes yet, but it's a very exciting study. And with that, I want to conclude with the acknowledgements. A lot of people work together on all these innovations. It's a snapshot, we do more, but I wanted to tell you about these 4+1 innovations. Also acknowledgements to the team of the Sexual Health Clinic in Amsterdam, here on the boat on the Canal Pride, and acknowledgements to all those in the H team. Thank you.
Thank you very much, Elske. This was very inspirational. Is there any question?
HIV transmission elimination in Amsterdam. Sorry, that's my mic.
Sorry. Somebody has a question there?
I'm very loud.
Okay, great. Okay. Here it is.
Okay, now I shall try not to shout because otherwise it's going to squeak. I was just curious to know, seeing some of your innovation seems quite tech heavy. How do you make sure that people who are not so tech savvy or who do not access the internet are not excluded? Seeing you're trying to reach the last people, really, because you're well on your way. So that was just really my question: how to make sure that you don't then exclude those who are not tech savvy, who don't have smartphones, who don't access the internet.
Yeah, thank you. That's very important, and I think this. Sexy Side of the Netherlands meetings is one of the examples that is really accessible to all people. And something else we do, we have a large sexual health center in the center of Amsterdam, but we also have outreach, so we go to the gay clubs and the parties, and we have clinics in areas in Amsterdam where a great variety of people live. It's walk-in clinics, mainly focused on young people, young MSM and young heterosexuals, many people with a migrant background. So, but we should keep telling ourselves to be inclusive to all populations. Thank you.
Okay, thank you, Elske. Thank you for your answer and your intervention. So we'll go on with the Prague case. This is a pre-recorded video because unfortunately our friends from there were not able to make it to be here with us. So let me introduce you to Jakub Tomše, who is a lawyer in an NGO based in Prague. So as you know, there's not so many cities involved in Eastern Europe or Central Europe. And what is doing this NGO is quite innovative. It has a quite innovative approach, especially with their prevention program and their communication program with towards the people living with HIV. So please, let's listen to Jakub Tomše.
Good afternoon, ladies and gentlemen. First of all, I would like to start with a short apology that unfortunately neither myself nor my colleagues made it to this event, even though we would have been really pleased to come to Sevilla and also to, spend some time with you at this event. My name is Jakub Tomše. I am a lawyer in Czech AIDS Health Society, so in an NGO based in Prague, Czech Republic, that's providing all sorts of support to HIV positives. Today I'm going to be slightly outside my comfort zone because this presentation is not that much about legal topics, but since I have been with the organization already for 10 years and have been involved in other projects as well, I've been asked to provide this presentation. On the first slide, you can see the content of this presentation. I will start with a brief introduction of our organization, and then I would like to cover let's say, the most important areas where we are active, both in the area of prevention, which is more, let's say, for the general public in order to prevent HIV transmission. And the second part is then services for HIV positives. At the end of the presentation, I would like to also cover the cooperation with Prague. I don't want to bore you with long historical explanations, but it's probably worth explaining that our organization is a non-profit and non-governmental organization that was founded in 1989, so in a year of big political changes in the Czech Republic. The primary purpose of the organization was support of HIV positives, so it was set up mainly by patients with HIV and by their family members, friends, and so on. In the coming years, or in the following years, this has then expanded also to the area of education and prevention. An important milestone in our history was the establishment of the social center, which is called the Lighthouse. It's based in Prague. You can see the building on the picture. And this is a place where we offer accommodation and social services to HIV positives, and also free of charge anonymous testing of HIV and other STDs. In the past years, we have become a countrywide organization, and besides Prague, we have opened 10 other checkpoints in the Czech Republic, and we also operate field ambulances focusing on anonymous testing. So as already mentioned, one of our core activities is testing of HIV and other STDs. We do have options in the Czech Republic to provide free testing of HIV. However, it's never anonymous, and there are sometimes also issues with access to it. Therefore, our organization represents a very important option to get this testing. Besides, due to the nature of our services, we stand very close to the target communities, like men having sex with men, and therefore every 7 diagnoses of HIV in the Czech Republic is actually found at one of our checkpoints, which is, I think, a very important coverage. Also, in the previous year, we have extended our services from HIV to syphilis, HCV, and HPV, where you can also see some of the recent statistics. This has also proven to be very important. We have been steadily increasing the capacities of our testing services, and we also try to reach out to people at various events or situations where there may be an increased demand in such a testing. So one example of this can be the Prague Pride, which took place in the summer, where our team was present, and where you can see that we have managed to test more than 2,400 people, and unfortunately, again, there have been some positive results that have been captured and found out as a result of this activity. The mobile testing in general is not limited only to Prague Pride and similar events, but our mobile facility is basically traveling across the country and offers this free of charge anonymous testing at many various occasions. 2 years ago, we have opened our own dermatovenerological ambulance. This was after some calls from the general public that this service is not always necessarily well available in Prague. And one of the services that we currently offer is also the subscription, the provision of PrEP. So pre-exposure prophylaxis is something that hasn't been really lawful and used in the Czech Republic until a couple of years ago. However, in the previous years, this has been made possible, subject to contribution from the patients. And as you can see, at this time, there are already several hundreds of clients who attend our ambulance and who are receiving PrEP services. Education is another important part of our activities. Of course, education about HIV can have very different forms. In our case, we have always put an emphasis on sharing of an experience of a lecturer who is himself positive and who, besides sharing the general information, can also share the story of her life. And this is usually, very well perceived by the students. We are recipients of subsidies from the Czech Ministry of Health, as a result of which we are able to offer these discussions to all schools across the Czech Republic. And in the previous year, a total of 109 discussions took place across the whole country. So now I would move from the area of prevention to the area of services for HIV positives. In this year, we have registered a new social service for HIV positive, which is called Contact Plus. And it's basically a sort of an umbrella for various services that are aiming to solve the problem of stigmatization and discrimination of HIV positives. So this includes psychological support, legal support, a support of a social services professional, also a support in the area of seeking healthcare, because this is still sometimes problematic for HIV positives, and of course any information sharing. So these all have been already provided in some form earlier, but the services quite often had to be covered by volunteers, and we are very happy that we have been able to make this in a slightly more, let's say, structured and professional way. Now I'm moving to one area that social service professionals sometimes don't really want to talk about, and that's chemsex. So basically a combination of sex with drugs and addictive materials. Here, our organization is the only social service provider that offers counseling and support, notably with help of psychologists who are experienced in this area. And we've been able to speak openly with our clients about this and offer them the support that they need to reduce the effects of their risky behavior, advise them on safer use of addictive substances, provide them with necessary motivation for abstinence and treatment, and let's say also contribute to a state where this is a topic that people are able to speak about openly. Since February of this year, Czech Republic has become a new home for more than 400,000 refugees from Ukraine. Unfortunately, one of the topics that also need to be addressed is their HIV status. Based on the statistics, almost 400 refugees have been HIV positive. And as you can see on the slide, approximately 64% of them have been in contact with our organization, and so providing aid for these refugees has been also one of our important goals this year. Of course, 400 people is not that much, and another topic remains to be the prevention of HIV among other refugees, which is also one of the priority that we are setting for ourselves for future, so that we hope that we will be able to offer testing to more people and hopefully detect other cases on time. One of the oldest social services that we offer is an asylum house and a hostel for HIV positive persons and for their families. Unfortunately, we are still seeing cases where these people struggle discrimination also when they are looking for accommodation services. Besides, offering the accommodation also gives us a great opportunity to start working in them on other areas of their life as well. In this year, as already mentioned, we have the refugee crisis, so we have also seen an increase in Ukrainians who are actually using these services. HIV positive people sometimes feel like they are being silenced or their stories haven't been really shared or listened to. And one of our goals was also to set up some resources for information sharing especially within the HIV community, but also in relation to the general public. Here you can see two examples of these services. The first one, Pozitivně, or in English, Positively, is a magazine that we issue bi-monthly with the purpose to share information about what's new in the community, what's new in the treatment, and share all sorts of information that can be relevant for the HIV community. The second service is actually a podcast that can be listened to on Spotify and many other places. Its name is Život Plus, so in English, Life Plus. And it's a combination of HIV topics with, let's say, other topics that are either about lifestyle in more general or LGBTQ plus community in more general. And we are very glad to see quite a big interest in both services. What we have been achieving so far, probably we couldn't achieve without the support of the capital city of Prague, so the city where our registered address and also our lighthouse is. The cooperation with Prague has been proving very efficient, especially in the previous couple of years. As you can see, they have been supporting our activities with quite an important subsidy, even though obviously we are receiving subsidies also from many other sources, including various ministries, including private donors, and so on and so forth. Also, the building where we operate most of our services, so the so-called lighthouse, has been rented to us for a symbolic fee. What I would also stress is that the municipality of Prague has helped us make the topic of HIV much more visible. So there have been various city events, notably a fun and run exercise. Also on the HIV Awareness Day, the city agreed to do some lighting of some public spots to remind everybody of the event. And Prague Pride is also another important example of this. As I have mentioned, the cooperation with the city of Prague has already been running for a couple of years now. However, we are very happy that it has been in this month when this has been formally, or this has been formalized by signing of a memorandum which outlines some goals and tasks that we should be working on together within a project of mutual cooperation. This includes community services, this includes testing and prevention, this includes improving the availability of PrEP and PEP and improving the quality of life of people with HIV in general. And the last point, we do believe that this will help us also increase the visibility of any prevention and preventive campaigns. So this is obviously a very good news. I'm coming to the end of the presentation. On a slightly more personal note, I just wanted to say that I'm really happy to see that our services have contributed to improvement of many personal situations and solving many matters. For myself as lawyer, I have seen many stories which, started in a not very good way, be it patients being refused by dentists or other doctors, be it employees who have been humiliated and stigmatized by their employers, be it people who have lost their homes and who have been, who have found themselves in a desperate situation in their life. And I'm really happy to see that our services have been able to bring a real change to some of these situations. However, of course, providing this type of help is also always a matter of receiving support from the appropriate stakeholders and also receiving the subsidies. So therefore, we are very happy that we are, based in Prague, and that also the cooperation, not just with the Czech state, but also with the municipality of Prague, is helping us make the difference here. So ladies and gentlemen, thank you very much for your attention, and I wish that this is a very successful event, and greetings to all of you. Bye-bye.
Thank you very much, Jakub. I know he's not live, but obviously, I thank him virtually. So For obvious reason, we cannot take any question for Prague, but if you do have something to ask, don't hesitate to come to me at the end of the session, and I could give you his email contact. So we'll pursue with the case of Odessa, Ukraine. We have here Irina Klitsenko, who is member of parliament of the parliament city of the city of Odessa. So please, Irina, tell us how people are doing there.
Hello, everyone. I know that you are tired, so hot here, but my speech will be not very long. My name is Irina Kutsenko. I'm a member of Odessa City Parliament. And all my situation about the HIV, hepatitis, the tuberculosis community start in 2017, because it was the date when our mayor declared the Paris Declaration.
Sure.
But before the declaration, declared the declaration, one young lady from NGOs come to my parliamentary office and said, Irina, you are a deputy. You need to save the peoples, because there are a lot of people dies, HIV, hepatitis, tuberculosis. You need to change the situation in our city. Then I come to the Harm Reduction Academy, which do the Alliance of Public Health. Big thanks for them, because it changed my mentality, my opinion about the situation. Because I want to close all all the sites of substitutional therapy. I didn't like to work with people who use drugs, MSM and others. But after the Academy of Harm Reduction, I will change my opinion. Our mayor declared the Paris Declaration, and we start to work. First of all, we start to unite all the non-governmental organizations, politicians, officials, people's doctors, and we start to work together. We understand that if we will work together, the situation will be changed. At first, we start to testing. We start to testing everyone in our city. We would like to change the opinion of our people that all people need to be tested twice a year. All peoples, not only from community, somebody, all people. Then we start to think that we need to give the money from the budget of Odessa city if we would like to change the situation in our city and in our country. At first we started to do the program, and in this program the budget was $2 million from Odessa city budget. Then now we understand that this is not very big budget, and if we would like to change something, we need to give more. And now our budget is $3.5 million for the community treatment, testing, helping, and then we start to do listening community. All communities for the question, what we need to change? And the community do with us, with the politicians, the program of Odessa city to HIV, hepatitis, tuberculosis, uses drugs, politicians and others. And we have a harm reduction program also in this program, and we give money for them. We also rewarded to doctors' salaries for identification and registration people with HIV, with tuberculosis, with hepatitis, and give money more. So our doctors start to be interested, to be involved in this process. So if I identification somebody and start to treat them, I will save a lot of money. So our doctors start to work good. Tomorrow in the morning will be the presentation about our doctors' speeches about how our medical hospitals and our polyclinics and others. Also, we understand that we need to have a self-injection room, and we working for them, but start the war in our country. And now we have a lot of problems, not only for people in community and HIV treatment, HIV testing, hepatitis, tuberculosis. We also need to understand what we need to do with people, because they want to eat. They want to have a house, because its building, its house will destroy it. People had the water in some cities in near Odessa city. Mykolaiv have problem with the water, also not only for treatment, they have a problem for life. So at the parliament, our mayor in our city, we understand that we need to help people who come to Odessa. There are a lot of people from community. This is more than 1,000 people come to Odessa, and these people this is people who have HIV, who have hepatitis, tuberculosis, and we need to treat, give houses, hostings, hospitals, and we need to be near the people. And most of all of you who sit here can change the situation in your cities, because you can come to your politicians, you can speak about the situation in your cities, and politicians can listen to you and change the situation in your city. So all is you can change. Odessa is also a city where war is start. And our buildings are also destroyed. Our peoples have destroyed life, but we have a power to change a situation. We can be near the people. We can give the treatment there. You can see some presentation, but I would like to say that after the Paris Declaration was declared, the situation in my city was changed. Now it's war, but we start to work more and more. We give more money than in a year before the war. We work with people, we test in people, we work together, because we would like to have a result. And not 55, 55, 95, 95, 95. We would like to have a 100 result. So thanks that you do in your cities. I can ask the questions. Sorry that Kiev cannot be here, because yesterday and day before yesterday Kiev was attacked by Russian bombs, and the speakers about the Kiev cannot be here. So I speak about Odessa, because our speakers cannot be here. So support Ukraine, glory to Ukraine. Thank you, big thank you for all who helps Ukrainian peoples, all cities, all countries. Big thanks from Ukrainians.
Thank you, Irina, for your intervention. We're very, sorry, I'm a bit emotional. We're very sorry about the sad situation people are going through there. We are with you. Is there any question in the room? Okay, you leave us speechless. That's understandable. So thank you again for your intervention. So we will go on with our last case with our dear host, Savier, Spain. So please, could you introduce yourself and tell us about how it works here in Sevilla? We're quite curious to know how our host fight against HIV. Sorry?
Sí, te la hemos dado antes. ¿Puedes ir, Leire, o no? Que dice que no tiene la presentación. Está grabada en el escritorio. Bueno, buenas tardes. Good afternoon to everyone. My name is Savier, and I am one of the persons who have worked together with the Fast Track Committee of Sevilla to conduct an external evaluation, a mixed evaluation of this plan, the Fast Track plans of Sevilla 2018 and 2022. And I am going to present very briefly, because the time is not, the results of this evaluation process. The Fast Track Plan of Sevilla had 5 objectives that are related to the UNUCIDA goals and 4 strategic lines. That the first one is related to health promotion and HIV prevention. The second one related to quality and comprehensive care for people living with HIV. The third one related to rights and equality for people living with HIV and key population and the most vulnerable groups. And the fourth one is related to the leadership of the City Council, that was who promoted together with the NGOs the plan. And the most important thing, or the most characteristic thing of the Fast Track Plan of Sevilla is the Fast Track Committee that is formed by 4 public institutions that are the regional health government, the local health government of the city, and also of the province of Sevilla, and the 4 NGOs that are Adara, Fundación Atenea Médicos del Mundo y Fundación Triángulo, and the University of Sevilla. The methodology that have been used during the evaluation process was mainly qualitative methodology, and we start conducting a documental review. We conduct also 2 workshops with the committee and 12 interviews with the committee and other NGOs and experts of the city of Sevilla, and online survey. And we organize all the information with dimension of analysis that are design processes and results that is based on the program theory. And also this dimension of analysis are related to the evaluation criteria that we use to do the evaluation. I am going to present some data, not all the whole information, because there is not enough time. But first of all, the city of Sevilla has almost achieved the 3 UNUCIDA goals. And this morning, the regional government present a study that is an estimation for Andalusia of these goals, and with this information that is really new. The first one will be 91% of people living with HIV knows their HIV status. The second one, the 98% of people living with HIV are on treatment, and the third one, 91% of people on treatment have suppressed viral load. And also the number of people with HIV on treatment, on care, has been increased during the years that the implementation plan. And the new HIV diagnosis has been decreased, but this is important to say that there is an underdiagnosis related to the COVID pandemic. And one of the main achievements that we would like to remark is the budget, but not the amount of the budget, that to have a plan in the city of Sevilla has changed the budget of the city council. The Sevilla City Council created a specific budget line and increased its HIV funds, but the other institution also has been increased the budget for HIV prevention. And one of the things that we analyzed was the usefulness of the plan, and the main uses of the plan were to define the goals and objectives of the members, entities of the committee, and also to align the actions between them. But another result is that Sevilla was in Spain the first city who have signed the Paris Declaration, and because of that and the first city that has this kind of plan, and because of that it's a reference for other cities in Spain, and this fact promote that the motivation of the members of the Fast Track Committee was increased, and also the political support and the visibility of the actions. And according to the guiding principles of the plan, the most developed were the cross-sectoral and partnership approach, the equity perspective and health accessibility, the commitment to the city, and the gender approach. And according to the 4 strategic lines, the most of the activities were included in the line 1, because the line 1 include health promotion activities, activities to promote the early diagnosis, all the campaigns, a lot of kind of activities related to health promotion. But in the others line, there was also results and activities, but I don't have any time to describe all of them. And this is the number of activities it's per objective online. I pass fast. And one of the points that I would like to remark is the activities to promote the early diagnosis, but the data is important, but for us the most important is that this kind of tests were targeted to most vulnerable population. I mean, if you see in this graphic, these tests were targeted to people who use drugs, population in prostitution, migrant population, and as you can see, the most of the activities were focused on general population and men to have sex with men and young adolescent population, but the other collectives are included, and also the activities were done in the context that this population live or normally are. And the main achievement for the first line was the recognition of the promotion of early diagnosis as a prevention measure in the City Council, because before the plan it was difficult to explain that the early diagnosis was a prevention measure. And also the completion of the sexual health guide with the participation of most of the members of the Fast Track Committee, and the implementation of joint awareness raising campaigns in a regular way. And the promotion of quality of life and improvement of the care has as the main achievement was to improvement of the coordination of the different actors to improve, and the promotion of positive equality and effective inclusion of people living with HIV, key population and the most vulnerable groups has as a main achievement the coordination of the actors involved in the defense of the rights of people with HIV. Only one example of the kind of activities that the Fast Track Committee has been developed is to eliminate HIV as a medical cause for exclusion of public employment for security corps of the state. And also there is a wide external recognition of the work carried out by the whole committee under the leadership of the Sevilla City Council. And 2 lessons learned. One of them, for us, the most important is the work of the Fast Track Committee. The Fast Track Committee has developed a lot of activities, but they improve a lot the coordination between them, and also is the most suitable space to continue working to the joint response of HIV in the city of Sevilla. And also to be part of a global initiative and working with the different actors involved in the response and with community entities has promoted scaling up of HIV prevention work in some contexts and with vulnerable population. And very, very fast, the challenge, the four first challenges are related with the design for the next plan, because the Fast Track Committee are now thinking in the design of the new plan. And for them, a challenge is to have a monitoring system. Now they have a monitoring system, but the point is to have a monitoring system with agile tools that were used for decision making, to incorporate a space to analyze this information for the decision making, and also to have a document, a concrete planning document, focus on the diagnosis, on the situation of the city, to work in an urban context that is the city of Sevilla. Identify also strategic and activities with added value to work in a municipal level, and in the evaluation process we call fast track activities, actividades fast track, that are activities that the committee implement together. But the challenge is to incorporate these kind of activities to promote pilot projects, to promote studies, to go pues más allá, ¿no? Yes. And the last one. Okay. Another challenge is to have a budget, because at the very beginning of the plan there is not a budget specific for the plan, and define the different functions of the members of the committee, and incorporate the criteria to incorporate new members based on the population that they want to work, and to have a communication strategy of the plan, promote the exchange of good practices with other cities in the fast track initiative. Okay, thank you.
Thank you. Thank you, Irma, for your presentation, and thank you for this, to finish on this optimistic note. Unfortunately, we won't take any questions because I don't want to shorten your break any further, guys. But I guess everybody's here to answer your questions after the session if you want to. So thank you to all the speakers who intervened in this session. Thank you, Nantes, Cardiff, Amsterdam, Prague, Savier, and Odessa. And thank you all for your attention. Thank you so much.
presenters on some of the work ongoing in their respective cities, including topics such as the effects of COVID-19 on health services to healthcare volunteers, and also each presenter will have 10 minutes on various topics. We will be introducing those topics as we introduce the presenters. I would like to perhaps mention in the beginning that we will allow all the presenters to make their presentations in terms of the oral abstracts, and after that we hope that we will find time to ask questions. So as we continue to make the presentations, please take your notes in case you have any questions. So I will begin by inviting the first presenter, who will speak on combined needle and syringe program on opioid against therapy, and that is none other than, sorry, Mbria Prince. Please take the audience.
Yeah, thank you so much. They just, yeah. Or maybe, no.
So as she gets ready, let me call the second person, and for that. So the second person is Mehek Ali. Do we have Mehek Ali?
Hi, yes, I'm here. I'm online.
Maybe joining virtually. Mehek Ali, are you with us?
Hi, yes, can you hear me? Hello?
Mehek Ali?
Yeah.
Oh, there she is. Welcome, Mehek Ali, and she will be presenting on enabling local response to build bridges for research with communities affected by multi-drug resistance tuberculosis in Pakistan. Over to you, Mehek.
Thank you so much. Am I supposed to be sharing the presentation myself, or is someone else?
We can't hear you, Mehek.
Oh.
I think you are muted.
Are you able to hear me now? Hello? Hello? Cedric, are you able to hear me? It's unmuted on my end.
So we will have that checked. I think it's a technical problem. So perhaps in the interest of time, as we wait for Mehek, we could go to the next presenter, and Mehek, we will come back to you. Hopefully, we will have sorted out the technical problem. So our second presenter is Juan Carlos Ruiz. Okay, Juan will be presenting on more. I think he will tell us about what he'll be presenting on. Thank you.
Okay.
And the floor is yours, Joan.
Okay, first of all, I'd like to thank the organization for inviting me to give this oral communication. My communication is titled More Hepatitis C Late Case Diagnosis and Aftermath of the COVID-19 Pandemic in Barcelona, Spain. Well, si la presentación estáis en ello, ¿no? See. Here we have the slides. So, in 2016, the World Health Organization advocated for the elimination of viral hepatitis as a major health threat by 2030. However, in January of 2020, the coronavirus pandemic forced this objective to be put aside. There have been many reports of the indirect cost of the pandemic. Here we bring this recent paper published in Lancet in 2022, which reports an excess of mortality due to COVID-19 of more than 18 million deaths, being only 6 million of them because of direct COVID deaths. To set some epidemiological context in Spain, we bring this paper which characterizes patients with hepatitis B and C. We are focusing in these results, seeking for first-time specialist care in Spain over a 2-year period between 2018 and 2019. I'd like to highlight that 27% of patients had late presentation and 5% of patients have a late-stage disease, meaning they had or hepatocellular carcinoma or descompensated cirrhosis at the time of first specialist care. In this context, we wanted to evaluate if the pandemic limited the access to first-time specialist care for HCV patients, and also to evaluate if the pandemic increased the amount of HCV patients with late presentation. To that, we performed this retrospective and prospective study between 2018 and 2021 in Valdebrón Hospital in Barcelona, Spain. We included all patients attending first hepatology consultation with chronic infection of hepatitis C, meaning they all had positive RNA. All patients were over 18 years old, and we excluded acute hepatitis. Patients were referred to us by a specialist care physician or other specialist. We recorded their demographic and clinical characteristics and separated them into 3 periods: previously to COVID-19, during COVID lockdown, and after COVID lockdown in 2021. Liver fibrosis was assessed by non-invasive methods, most of them by transient elastography. We used this definition of late presentation for care proposed by Maus in 2017, which includes 2 types of patients. First of all, patients with advanced liver disease, meaning these patients have a significant fibrosis assessed by one of the following methods: serological scores, transient elastography, or liver biopsy. And also, this definition includes patients with a more advanced liver disease, which is called late-stage liver disease. This includes patients with descompensated cirrhosis and hepatocellular carcinoma. Here we present our results. A total of 376 patients with hepatitis C were visited during this period, 229 before and 147 during COVID-19 pandemic. This, as you can see in the red arrow, represents a decrease by 36% of patients attended. If you see the graphic, you can see that similar number of patients was attended during COVID lockdown and after COVID lockdown. Also, in regard of the baseline characteristics, most of them were male and the mean age was 58 years old, which is slightly older than previously described. We also recorded the birth of the country of birth of our patients. In our cohort, 77% of patients were born in Spain and 23% outside Spain, predominantly from Eastern Europe, Pakistan, and South America, as you can see in this color code map. In this slide, we can see the percentage of patients with late presentation. In blue, there is the total number of patients attended in each period we described. And also in the orange column, we have the number and the percentage of these patients that had late presentation, meaning that they had already established fibrosis at the time of first hepatology visit. As you can see, 42.5% of patients attended in 2021 had late presentation and therefore significant fibrosis, so they will need a long-term follow-up with ultrasound because of the risk of hepatocellular carcinoma. In this other slide, we can see the number of patients with later stage liver disease. In blue again, the total number of patients in each period, and in the orange column, patients with later stage liver disease. The orange column includes the gray and the yellow column, being the gray patients with hepatocellular carcinoma and the yellow patients with descompensated cirrhosis. In order to analyze this data, we need to zoom in the bottom of the graphic. First result we want to highlight is that no patients with later stage liver disease was visited in 2021. We think this is due to the fact that it's an infrequent event and we had a limited number of patients, and not because they had a less advanced liver disease. Also, we wanted to highlight that we have a similar number of patients with hepatocellular carcinoma, but we had less patients with descompensated cirrhosis. We think this is due to the fact that at our hospital, patients are usually diagnosed of descompensated cirrhosis at emergency department or hospitalization, so they enter the consultation in another circuit. In conclusion, the COVID-19 pandemic caused a reduction of outpatient attendance at first hepatology consultation by 36%. This limited access to screening and diagnosis could have increased the percentage of patients with late presentation for care in 2020, and also this could lead to a delay in global and World Health Organization elimination plans for HCV.
Thank you, Mehek, Ali. The next person will be Juan Carlos. Oh, you're the one. And I'm going back to Mehek Ali. sorry about that. So, Mehek, you take the floor.
Oh, sorry, is it coming to me?
No, I'm Maria Prince.
Lord. My apologies once again. So we will go back to, maybe we will give the floor to Prince, and then we will hear Mehek on the third presentation.
Thank you very much. I hope my presentation, this is not my presentation. So, can I have them? Yeah. Thank you. Yes, perfect. It's here. It arrived finally in Sevilla. Yes, from Amsterdam. That's far away. So I'm going to talk about the effect of harm reduction programs for people who inject drugs, and I will focus on a meta-analysis of emulated trials. I will explain later on
what that means. But first of all, I would like to draw your attention to this picture. This is not me 25 years ago, but it is Daniela van Santen, who was very committed to do this work. And she couldn't be here, so I'm presenting, and I'm also the lead author of this work. But going back when I was a teenager, because at that time there was already a heroin crisis in Amsterdam. And at that time the Public Health Service, that's the service I'm working, provided opiate agonist therapy, and that time methadone, to the city districts in Amsterdam. In the city districts where we could find people who inject drugs. And quite interesting, already in 1984, shortly after the start of the HIV epidemic, it was the community who started needle and syringe programs in Amsterdam. It was called the Junkie Bond, and once they started, the Public Health Service took over and they combined both interventions. Of course, we tried to monitor what happened in Amsterdam, and we could because we had a cohort study among people who inject drugs. And what you can see on the left panel is that both hepatitis C and HIV incidence went down over time. At the right panel, you can also see that the population that started injecting drugs, who had its peak at the end of the 1970s, went down. So we were very curious already in whether we could demonstrate that those programs were helpful in reducing the risk of acquiring HIV and hepatitis C. So we did so in that cohort study, and we find an association between full participation in those programs and a reduced risk of hepatitis C and HIV. But this is a cohort study, so you talk about associations and you can't demonstrate a causal effect. The second thing we did, because we want to be sure, is that we modeled also using the data from that cohort what happened if you didn't have harm reduction. And that's shown on the lowest slide, where you can see the blue line. If you don't have harm reduction, you also see a decline. And that's because the proportion of people starting injecting went down, and also because those of highest risk of HIV at that time and deadly disease were no longer in a population and could transmit the virus. So that's how we moved on. Go back, yes. But, like I told you, these observational studies, so when you look to scientific evidence, it's called weak, because you don't have a trial, because you can insufficient adjust for confounding and selection bias. Like that people starting programs are more likely or less risky. So what you would like to do is a randomized controlled trial in which you compare harm reduction with no harm reduction. But that's not ethical. You can't do that because those programs have proven to benefit across a whole range of outcomes, and it's impossible and unethical to do such a trial. But what you could do, there's a new statistical technique, relatively new, it has been applied to CART, the effect. You can use emulated trials using data from observational study. So we did in Amsterdam, and again we found a reduced risk of HIV, hepatitis B, and hepatitis C, very confirming new evidence. However, you can also argue that from one setting that's not sufficient evidence. So we try to find cohort data who have the specific information from 3 different settings. Actually, we also looked for data from middle and low income countries, but they didn't have sufficient data to do this kind of analysis. But we got data from Canada, 3 continents, Netherlands and Australia, and all those countries were early adapters of harm reduction programs. But there were still different epidemics, and also the population differ. Like HIV has never been introduced in Australia, drug consumption was earlier in Amsterdam, and also components of corporate coverage differs between countries, and the market for illicit drugs are also different. So again, we look to the effect of comprehensive NSP and OIT participation on the HIV and hepatitis C infection risk. And except using data, we used again data from Amsterdam, from the Amsterdam cohort studies, but also from VIDES, from Vancouver, and from Supermix from Melbourne, and again in a population at risk of infection. I'm not going to explain this emulated trial, but here you can compare what you do in a randomized control trial on the left and in an emulated trial. And you try to be as close as you can be to a target trial. So you can say it's second best. What I would like to highlight here is that the intervention strategy, normally you would have no uptake of harm reduction, partial uptake and full uptake. That's what we would like to do. But because most of those countries had some form of program, we couldn't evaluate the proportion in a group of no harm reduction was too small. So we compared no or partial participation in this program of full comprehensive participation. And this is the most important slide of my presentation. This shows the results when you do an emulated trial within each of those cohorts, and also it shows at the bottom the pooled, the total estimate when you combine those data. So when you look to HIV, there is a much lower, a 64 lower risk of HIV infection when you participate in complete harm reduction. And when you look to hepatitis C, the effect is even stronger, and it's almost 69%. So to conclude, when applying a target trial to infer causality, so again, the second best approach you can do, we found a substantial reduction in hepatitis C and HIV acquisition compared to no or partial participation, and we saw that in different settings in high-income countries. These findings, coupled with the fact that this intervention is associated with reductions in drug use, criminal activity, and mortality, and with engagement in care, these findings reinforce the critical role of access to harm reduction programs. And it also suggests that WHO should emphasize access to the comprehensive components, both components, rather than one component separately. And given that most countries lack access to those comprehensive programs, and still 10% of the people acquiring HIV infection in 2021 are people who inject drugs, it's very unlikely that we reach elimination goals by 2030 unless we really have increased access of this key intervention that is really vital to preventing new infections. And I would like to thank my international team of co-investigations, and especially Daniela van Santen, and also the participants of the cohorts and the cohorts personnel, the funders, AIDS Foundation, and thank you for your attention.
Thank you very much, Maria Prince. Let's keep on putting down our questions as we had mentioned earlier. And I will now call upon the third presenter, Mehek Ali. Let's hope you have sound now. Mehek? Perfect.
Hi, are you able to hear me?
Yes. Yes, we can hear you now. Please go ahead,
Great.
Mehek.
Should I just share my own screen? Would that be easier?
Please share the screen, yes.
Okay. Okay. I hope my screen is visible.
It is visible.
Okay, great. So hi, my name is Mehek Ali, and I lead community engagement at IRD Global. And today I'll be talking to you about how to establish local responses to build bridges for research, particularly within communities that have been affected by MDR-TB in Pakistan. So Pakistan contributes about 5.7% of the global TB burden, and it's one of the highest incidence rates of MDR-TB. We have on average 25,000 drug-resistant cases a year. So to combat this, the Ntb Clinical Trials, which are a multi-country phase 3 trial testing the efficacy of shorter-term treatment regimens for our MDR-TB, are implementing 2 studies in Pakistan. So the first one, which is the Ntb study, was initiated in 2019, and patient recruitment for that is now complete. And the Ntbq clinical trial, which was launched in 2020, has its recruitment ongoing. But as you can see here on the map, we have 2 implementation sites within Pakistan right now. The first is within Karachi city, and the second is in Kotri town. These are supplemented by follow-up visits that are conducted by mobile clinics in the regions of Dadu, Badin, and Mirpur Khas, which are all within the province of Sindh. Now, while clinical trials produce critical evidence on the efficacy and safety for health and treatment regimens, due to rigorous research protocols and resource limitations, they may fail to include community voices in decision-making. And it's quite evident when we look at patient stories and stories from treatment supporters that they typically have a limited understanding of the disease, as well as how to manage the treatment itself. So these are factors that might be inhibiting person-centered care. They do create mistrust in the community, and they can hinder uptake of treatment post close of research. So this warrants the need to have some sort of immersive community engagement practice that re-examines the current patient protocols in place. In particular, since TB is considered a social disease which disproportionately affects marginalized and vulnerable populations, in collectivist cultures like Pakistan, it may warrant really engaging families and communities more actively to improve patient care as well as linkage to services. So to address this, in Pakistan, we are collaborating with communities to foster ownership and research and TB services through a unique community action group model, or CAG as we refer to them. So unlike a traditional community advisory board, which typically has experts and professionals and technical people that may not represent real, true lived experiences, the CAG model focuses more on inclusion of people with lived experiences, as well as marginalized communities for health programming, research, and community action. And this takes a socio-ecological model, which includes TB survivors, who are those who have direct lived experiences, their caregivers, which could include family members, friends, or even current and previous treatment supporters, and local health practitioners or providers, who are often the trusted community health experts and are the first access point for care for patients. So in order to build this community action group, we took a three-phased approach. In the first phase, we wanted to understand lived experiences. So we worked with de-identified data from the free TB clinic to select patients to interview on a semi-structured interview guide. And the point of this was to understand changes in lifestyle prior to and after treatment, as well as any other insights regarding access and barriers to care. In particular, we were interested to see what kind of support functions people who were on treatment found while they were undergoing service access and uptake. In the second phase, we focused on identifying allies, and our expectation was that from the people that we interviewed, we would get nominations of individuals who would be willing to be part of some sort of community volunteer group. So once we received this nomination of persons, we conducted informal interviews to gauge their motivation and willingness to be part of this volunteer group. And in the third phase, we launched towards community action by inviting all the nominated people and initiating them formally into the CAG. After that, we hosted monthly meetings, which has resulted in an emergence of community action and activities that are hosted and autonomously led by this volunteer group itself. So in order to create goals that the CAG would work towards, we worked in a triad model. So we wanted to understand what are the needs of a clinical trial research team, what are the needs of integrated public health programs, and what are the needs of the community and patients themselves. And so using this triad model, we formulated 3 goals with the CAG. The first was to improve knowledge, health knowledge in communities. It was originally focused around TB, but recognizing the social determinants of health, this expanded to other health topics as well. The second was to address stigma and garner support for people who were affected. And this was something that the CAG members wanted to take on themselves through community outreach activities. And the third was to increase understanding of research to foster meaningful participation and to reduce fears of exploitation, which was something that we saw quite commonly in communities. So we currently have 2 CAGs that are operating in the city of Karachi, and we hope to expand these further to the remaining the remaining city of Karachi, as well as to the other sites that were shown on the previous slide. Both of these areas are a high MDR-TB prevalence site. And as you can see on the map, this indicates that while community members gather at a centralized point, their geographic spread is quite vast, suggesting that there is an ability to decentralize provision of care and services if you utilize this kind of model. So in total, we have about 24 active CAG members. And I think what's important to note here is that there seem to be twice as many women who have remained active in the CAG. But of course, this also we need to acknowledge that this might be that men are typically unavailable for meetings during the day because they might be involved in formal care, especially in low-resourced communities, as is in our context. But the second interesting point to notice is that the bulk of the CAG members is actually comprised of caregivers, which suggests that they might have some sort of intrinsic motivation to be part of a volunteer group because they might have taken care of their loved ones who were affected by this disease. So when we reflect back on the kind of autonomous action that community members have taken along 3 goals, the impact is quite astonishing. CAG members have requested to be trained on and have been trained on multiple topics such as TB, mental health, COVID, Hep C, hypertension and diabetes, and SRHR. They've also identified that they want to be trained on basic life support, which is something that we're working towards in the next few months. They've conducted over 55 awareness sessions with almost 500 community members and have linked us to 12 local health providers with whom we are building a robust referral network. In addition, the CAG members have been doing verbal screening for TB and have referred people to the site. So from all the people that they've referred, 44 have actually shown up at the clinic for TB screening, of which 6 were diagnosed with DSTB and 2 with MDR-TB. They've also facilitated 14 X-ray camps with the help from IRD's TB programs, resulting in over 1,000 people screened for TB, reaching the national TB program's goals for active case finding. They've also worked very actively on providing rations to communities that are affected by natural disaster or are impoverished. So this was in particular related to during the month of Ramadan, which is the month of fasting, during the peak of the COVID-19 pandemic, as well as during the past monsoon seasons, which have wreaked devastation in Pakistan. And in addition, these CAG members have integrated with other public health programs within IRD as well, such as providing screening and vaccination services for COVID-19, referral systems for mental health, and other TB services. And finally, when we look at their impact in terms of research, they have provided critical feedback on Ntb trial protocols and processes, as well as how to orient patients to clinical consent forms, how to onboard treatment supporters in a way that is inclusive and easy to understand. And they are beginning to understand their rights as patients. They've also conducted site exposure visits and participated in multiple surveys and focus group discussions following membership in the CAG. Now, while the previous slide shows some of the numbers that this CAG has been able to achieve, which shows that it's possible to decentralize services and use a community-based model, I think the real question that is warranted is what is the effect that this really has on CAG members themselves? And while we're working to measure this in a more impactful way, we have heard from CAG members that they value being a member of the CAG. Through a recent survey, we saw that CAG members demonstrated improved knowledge in the health topics that we've trained them on, and they've also self-reported improvements in their own self-efficacy or motivation, and have talked about an increased social capital. And such enablers legitimize the informal work that community members and representatives might already be doing. But more importantly, it offers a structured and systematized way to measure this impact and scale it. In a cost-effective way. So in conclusion, what these early findings from the CAG model represent is that there's an urgent need for inclusion of lived experiences and local voices in building a sustainable and decentralized model for TB care. And this is true for not just TB, but other health diseases, because we have tested this model in other health areas, and it seems to be disease agnostic. We also emphasize the merging of the benefit of patient-centered care and community-based support as positive drivers for treatment outcomes, which might impact policy change. And finally, I think it makes it imperative for public health programs and research to integrate community engagement quite early on, so that this ensures that these learnings are implemented in a real-world setting before those policies are drafted or putting those policies into practice later on. So thank you. I'd like to thank the CAG members, without whom we would not have any kind of nuanced understanding of those lived experiences, as well as our team that really believes in the importance of community engagement. So we really hope you enjoyed this presentation, and we're available for questions if you like. Thank you so much.
Thank you, Mehek, for that presentation, and we will very quickly move to the next presenter, and that's Anna, seated just next to me. And I'm trying to pronounce your second name, and I apologize if I pronounce it in English. Or maybe it's better for you to say it yourself.
Thank you very much. Thank you. Okay, good afternoon, ladies and gentlemen. Today I'm going to present our project called Ntb, which is a new approach for identification and linkage to care for people living with chronic hepatitis B. Hepatitis B virus affects more than 296 million people worldwide, so it has a prevalence of roughly 3.9% worldwide too. Chronic hepatitis B could lead to advanced liver diseases such as fibrosis, cirrhosis, and liver cancer, and has a high rate of mortality. For this reason, hepatitis B remains related to a high health and economic burden. And as you may know, chronic hepatitis B is mainly an asymptomatic infection, and it is estimated that 90% of people are undiagnosed worldwide. So there are a large number of individuals living with hepatitis B and not linked to care. So in one hand, they cannot receive treatment, which increase the risk of hepatitis B advanced liver diseases, related advanced liver diseases. And on the other hand, it does not allow the World Health Organization goals by 2030. So Ntb study wants to contribute to remove this barrier to care and to achieve this global purpose. And our aims were to promote the linkage to the specialist of people with hepatitis B, to determine the barriers of linkage to the specialist, and to characterize hepatitis B surface antigen positive individuals not linked to the specialist. So this study is a unicentric study performed in a tertiary university hospital of Barcelona, and it is based on all hepatitis B surface antigen positive cases recorded from 2018 to 2020 in a retrospective part, and from 2021 to June 2022 in a prospective part. And to give you an idea of our area of study, our microbiologist department is a reference laboratory of Barcelona and has a catchment population of 450,000 inhabitants. So it receives samples from 15 primary care centers and centers for drug addictions. So the methodology was that all surface antigen positive cases recorded in our laboratory were collected, and then we export the baseline data from our laboratories such as age, sex, solicited center, transaminases values, etc. And from all these cases, we revised the medical records to identify if these patients were, these individuals were linked to the specialist and the reasons why not. So individuals linked to the specialist, no further interventions were done, and those individuals not linked to the specialist, from them, clinical and demographic data were collected, and we contacted with them by different via, such as phone, letter, email, or phone message, to schedule a blood test and a visit with the hepatologist of our center. Blood tests consisted in a hematological and biochemical profile, hepatitis B, delta, and C biomarkers, HIV, and non-invasive markers for fibrosis, liver fibrosis. So finally, the infection stage of these individuals could be classified, and individuals who meet the treatment criteria were provided by antiviral treatment. So these were our results until May 2022. We recorded 2,657 positive cases in our laboratory, and we found that 64% were appropriately linked to the specialist. But we found that 946 individuals were not linked, which represented a 35%. Among them, we could contact it to schedule an appointment with 593 individuals, and from this group, a 40% did not attend our appointment, but we could visit 285 individuals, which represented achieving a 48% of retrieval rate. Okay. It doesn't work. Could you please put the next slide, please? Por favor, ¿podéis poner la siguiente diapositiva? Sorry. Okay. A little break. Okay, it's okay. Okay. Thank you. So, focusing on the reasons for not being linked to the specialist, we found that we found two main reasons. First, the non-referral of primary care physician, which represent the 30%, and second, the patient that do not attend their visits, which represent a 23%. Other reasons found were programmation matters related to COVID-19 lockdown. 11% had moved to another region, 9% had death, 3% had been referred to the primary care physician again, and 3% had acquired a functional cure. So what about the differences between people linked to the specialist and those not? As you can see in this table, we found that the group of people not linked to the specialist were younger, with a 44 median age, had a higher proportion of males, 66%, had a higher platelet count levels, but without clinical significance. There were no differences between both groups regarding transaminases values. And regarding the HBV DNase levels, the group not linked to the specialist had a slightly higher levels and lower levels of surface antigen. Individuals E antigen positive and co-infected by hepatitis delta and HIV were more likely to be linked to the specialist. And about the differences between individuals that were visited and those who did not attend the visit, we found that those visited in our hospital has a 39% of Caucasian individuals. And in contrast, those who did not attend the visit had a 40% of individuals from Africa. They were younger and they also had a higher proportion of males. In contrast, individuals visited had more individuals with increased transaminases levels. So finally, we can conclude at this time that more than 1/3 of recorded hepatitis B surface antigen positive cases were not linked to the specialist. The main reasons for non-linkage to care were non-referral by the primary care physician and non-attendance of patients to the visits. Individuals not able to be linked were mainly middle-aged African male. And link B is retrieving more than 1/3 of hepatitis B surface antigen positive individuals that were not linked. And finally, I would like to thank you for your attention and my problems. Thank you.
Thank you, Anna Fella-Prus. Am I correct? Fella-Prus. Thank you so much. The next presenter, and I think she'll be, you want to go first? There's somebody else. We have somebody online, but perhaps we can give the chance to, okay. So we have Cedric Felalani Sosibo, who is going to speak on use of cohort tracing in eThekwini to ensure HIV and TB patients continued treatment and care following a social crisis and health emergency. Cedric, are you online?
Yes, hi, can you hear me?
Perfect, okay. Please go ahead.
Can I please try and load the presentation?
Please try.
I'm not sure if you can see it.
We can see it. Perfect.
Okay, thank you. I'm Dr. Sosibo from the Health Unit of Etegwini Municipality. It's located in the province of KwaZulu-Natal in South Africa. My presentation is derived from the abstract entitled "The Use of Cohort Tracing in Etegwini to Ensure HIV and TB Patients Continued Treatment and Care Following a Social Crisis and Health Emergency." This is the work that was done by a team of investigators from both Etegwini Municipality and the Health Systems Trust of South Africa. This slide here summarizes the processes that Etegwini as a district put in place to recover from external factors that affected the retention of patients, particularly our patients who are in the HIV treatment program. Essentially, there were three external events that we experienced as the city. The first one, we are all familiar with COVID-19, with its recurring waves. In our context in Etegwini, the waves of COVID-19 were by and large managed through nationwide lockdowns, amongst other strategies. The reason why lockdowns were important in as far as our patients were concerned is that the lockdown caused restriction in movement, which resulted in reduced access to healthcare facilities for patients. As shown in the graph here, during the first hard lockdown, there was a significant drop in the use of public health care. This resulted in a drop that we can see there from patients pre-COVID of about 451,000 in care, dropping to about 436,000 around the time of the first wave. And maybe just for the background, the first case of COVID-19 was reported in the city on the 8th of March 2020, and it was driven by the Alpha variant. What is significant during this first wave as well is the district of Etegwini experienced the drop that I had mentioned, but it happened around the end of the quarter of June 2020. The graph then shows a period of recovery which took place around September, when the second wave of infections started worsening through December and peaking on the 1st of January with 3,616 cases reported in just one day. At the time of the peak, I must say that there were more than 22,000 active COVID-19 cases in the city. This just illustrates how severe the second wave of COVID-19 infections was. And we should add that this wave was driven by the Beta variant, which had been confirmed to be highly infectious. Unfortunately, then, both healthcare workers as well as our residents were severely affected during this time. The impact that the second wave had on healthcare, the healthcare community, resulted in further disruptions in the healthcare system, which resulted in a further drop in our TROA. That is the total number of people remaining on ART, as we can see in the graph there, indicated as 435,645. Subsequent to this, around February 2021, there was a period of recovery again, which resulted in growth in our TROA. At this stage, our TROA even reached pre-COVID-19 numbers. It's also indicated there as 451,402, and we are comparing this to the baseline of 451,768. So this growth persisted for a while until we were hit by the third wave of infections between April and May 2021, which resulted in another brief lockdown. This third wave of infections was driven by an even more infectious Delta variant. The impact, however, was not severe since vaccination had been rolled out from March 2021 in the country. Nonetheless, the third wave still affected our TROA, causing it to stagnate with no net gains or losses to the number of people remaining on treatment. The second then external event that I would like to talk about is the civil unrest that we experienced around July 2021, during which the city was besieged by rioters. What is significant about this particular event, also shown in this diagram, is that even though our public health facilities were not directly affected, they still had to close down for about a period of 7 days for safety as well as other reasons. In addition to this, a number of our pickup points where patients usually access chronic treatment were also affected. All this had an impact on the ability of patients to access treatment and care, and therefore caused a further stagnation on our TROA. The third external factor that we experienced as a city was floods. I must mention that once more, following the civil unrest, there was a period of growth in our TROA, which can be seen on the graph. This growth continued until we then experienced two devastating floods in April and May of this year, that is 2022, across the entire metro. This resulted in substantial disruption in access to treatment and care for our patients. And I should state that we sort of had become rather resilient with the lessons that we had learned dealing with the first two waves of COVID. And then despite this experience as a district, we then worked hard with our partners, NGOs, civil society, and the residents themselves to try and restore normalcy in the metro. And I must say that our efforts still continue unabated even to date. I will then briefly discuss each of these events a bit more. Starting by this one, this graph it just focuses on the impact of the first hard lockdown that occurred around April. The lockdown actually lasted from the 27th of March to the end of April. And during this period, all movement except for emergencies or essential work was restricted. This then resulted in an immediate fall in the number of patients on treatment as people could not collect their treatment, and others missed their appointments after leaving the city to complete the remainder of the lockdown period in their rural homesteads. Unfortunately, even some patients missed the appointments because they were not sure if the traveling to collect treatment was regarded as an essential reason for movement. During this period, as shown in the graph with the red arrow pointing to the right and downwards, 3,236 patients interrupted
Dr.
their
Filalani.
treatment.
If you could move a little bit faster, I think we are running short of time, and I just needed you to be aware of that.
Okay, thanks for notifying me. So perhaps just to mention, to counter these, the district worked with HST primarily to identify the cohorts of missed appointments, actively trace them, bring them back to care, and then within months of between May and early June, we were able to succeed this. And in addition to these strategies, we also accelerated the process of decanting adherent patients to external pickup points so that we could further decongest facilities. And I must say, decongesting facilities certainly assist in making treatment more accessible to communities. I'll just move fast to the last 2 slides. Just to mention that this is briefly the good practices that we thought we should share in terms of how we instituted our interventions, and a summary here listed as a stakeholder engagement, performance management, allocation of resources, as well as good data management. Thank you. These are the people who assisted me with the presentation.
Thank you very much, Dr. Felalani. Our next speaker now is Elisa. Eliza Savier. Thank you very much. Please go ahead, introduce yourself, and then also tell us what you're going to present on.
Good afternoon, everyone. My name is Elisa Savier. I am a specialized nurse with a postgraduate in health project management. It's a pleasure to be here to present the work we are doing with focus in Madeira in order to eliminate HIV and viral hepatitis. Well, for those that don't know, Madeira is a Portuguese archipelago located in the Atlantic Ocean off the African coast. The Madeira Health Service provides care to more than around 250,000 people. It comprises 3 hospitals and 47 health centers. Our emergency department handles close to 90,000 episodes a year. Today, I will share how we use the focus test model to guide our implementation of HIV and HCV elimination plans. Tests were integrated with other existing blood tests. The electronic health record was changed to automate the identification of eligible patients and to automate test orders. The program was adopted by all involved organizations in the region, and not just hepatologists or infectious disease doctors. And the staff were trained in the new procedures. The integration of tests was gradual in terms of viruses tested and also the testing sites. We started with hepatitis C in 2019, including confirmation of active infection in the same sample for the first time in Portugal, and then included HIV in 2021. Regarding testing sites, we started with hospital wards in 2019, followed by the emergency department in 2020, and primary care centers in 2021. This is our electronic health record workflow. The system automatically determines eligibility for admitted patients who need blood work for any reason. We test everyone aged between 18 and 70 years old, except those with a previous positive test or a previous negative test within the last year. The system automatically adds serologies to patients' blood requests, and the nursing staff asks for patient oral consent. We ensure this program is a systemic policy, defended by all players in our region. This includes the regional government, the healthcare service, healthcare workers, and community organizations. We also provide visible information to patients so they know screening is the new standard policy for everyone. Staff training is also a very important process in the hospital and in healthcare centers. We explained our program goals and what we would need to do and what they will need to do to help us achieve them. We also send out regular communication with program results, so all the staff feel included in our success. By the end of June, we had screened over 49,000 patients. We found an antibody prevalence of 0.5% and a prevalence of active infection of 0.2%. We found 43 new patients who would not have received their diagnosis in a timely manner if they were not for our screening program. We are happy to tell you that we linked to care 94% of the cases. An analysis of the quarterly moving averages of antibody and RNA prevalence in the population reveals a decreasing trend over time. We can see that we will cross zero between 2024 and 2026, ahead of whose eliminations goal for 2030. Of course, we need to perform a more advanced analysis, taking other aspects such as viral transmission and disease progression dynamics into account. But this is a sign we are going into the right direction. Now the conclusions. The test model enabled us to increase and sustain testing across clinical settings, wards, primary care, and emergency departments. Opportunistic HCV screening revealed higher real-world prevalence than previously estimated for our region. Increased testing and decreasing prevalence trends mean we will likely achieve HCV elimination between 2024 and 2026, ahead of whose elimination goal for 2030. So thank you for listening, and I hope our results inspire to innovate in delivery of population screening programs in your countries. Thank you.
Thank you, Eliza. Thank you very much. The next presenter will be from an experience here in Savier, and we'll be talking about what happened to tuberculosis diagnostic delay during the COVID-19 pandemic. And that will be presented. I'm going to ask my neighbor here to pronounce that name for me.
It's going to be presented by Valme del Rio Garcia.
You can see for sure that I was not going to make that one. So we are going to invite the next speaker, and I think that will be online. Are we there?
Valme del Río García. No, no está. They don't have his presentation.
Okay. So if maybe we could then jump to the next speaker and the last speaker, and that is Sindhu, who will be speaking on poor HCV literacy among men who have sex with men. And over to you, Sindhu. Please introduce yourself and the topic that you will be speaking about.
Thank you very much. Let me share my screen. Okay. So hi, everyone, thanks so much. My name is Sindhu Ravishankar. I'm the Vice President of Programs and Research at the Fast Track Cities Institute, which is part of IAPAC, the International Association of Providers of AIDS Care. This presentation is on poor HCV literacy among MSM as a barrier to HCV elimination. So right now we know there are estimated 58 million people who have chronic hepatitis C infection and an estimated 1.5 million new HCV infections that occur annually. Although we do have direct-acting antiviral regimens that support the sustained viral suppression, we're quite off track in meeting the WHO goal of HCV by 2030 that many of the presenters before me have also cited. And this is even more so among key populations, including men who have sex with men. So this study was actually an online survey that was fielded in 6 countries. Actually, it was fielded in 7 countries, but one of the countries is not included in this analysis. So this analysis looks at Canada, France, Germany, Italy, Spain, and the United States. It was additionally fielded in the UK as well. All of the respondents were self-reported as men who have sex with men and were over the age of 18. And the aim of the survey was to understand perceptions that men who have sex with men had about HCV and literacy and kind of knowledge around both HCV testing and treatment. So a total of 1,400 participants took part of the survey. Then we took the survey from the 6 countries and analyzed the data that were coming from 44 fast-track cities across the 6 countries. So in Canada, we had 3 cities, France, we had 3 cities, 4 cities in Germany, 2 cities in Italy, 4 cities in Spain, and 28 cities in the United States. We then aggregated the city data by country. So really this is looking at data, at the data of fast-track cities within each of these countries. And I just wanted to share with you a couple of the key findings from this survey. So one is that more than half, or 53% of global respondents said that they lacked information about HCV and how to prevent infection. And when we look at this graph here that looks at kind of the aggregate data from the fast-track cities in each of these countries, we did not have this for the US, but for the 5 countries that did report on this data, we see that French fast-track cities, about 65% of respondents in French fast-track cities said that they lack information about HCV and how to prevent infection. And even the kind of the lowest value is still pretty high at 42% in Spanish fast-track cities, saying that they lacked information on HCV and how to prevent infection. Although there is a successful HCV treatment that we know can lead to cure, there were 18% of global respondents that did not believe it was possible to cure HCV, and 26% of global respondents who were not sure whether HCV can be cured. When we looked down in the breakdown of the fast-track cities in the 6 different countries, we see that in the Canadian fast-track cities, we see that, actually in the German fast-track cities, we see the highest percentage of people who don't believe it's possible to cure HCV. And we see in US fast-track cities, the highest, or 35% of respondents that are not sure if HCV can be cured. So again, this kind of demonstrates a lack in HCV literacy, particularly around treatment and cure. Almost half, or 49% of global respondents confirmed they have been tested for HCV, and 22% of those received a positive diagnosis. So we see here the range of respondents confirming that they've been tested for HCV ranges from 33% in the US fast-track cities to 60% being tested for HCV in Spanish fast-track cities. Of the 1,400 respondents, there were 294 who reported that they believe they are at risk for HCV infection. However, only 50% of these 294 respondents said that they would be very likely to get tested if they thought that they had been exposed to HCV. And we see here in particular that in Spanish cities, there's a larger percentage, nearing 50% of respondents saying that they believe they are at risk of HCV infection, and about 25% who are very likely to get tested. And in the other countries, particularly if we look at Italian and French fast-track cities, we see that the proportion who are likely to get tested even upon risk of HCV infection is pretty small. So based on just this broad survey, we see that there's still quite a lot of gaps around HCV treatment and cure literacy. There is also hesitation around testing for viral hepatitis. And this poor HCV literacy, particularly among MSM, is contributing to suboptimal levels of testing and treatment among this key population who are very vulnerable to HCV infection. And if we really want to reach the WHO targets for diagnosing 90% of people living with HCV and treating 80% of those by 2030, we need to really be closing the gaps in these key and vulnerable populations, particularly across the HCV care continuum for MSM. And just lastly, wanted to acknowledge the co-authors. The survey was a joint collaboration between Gilead Sciences, World Hepatitis Alliance, and the International Association of Providers of AIDS Care, and was funded by Gilead Science Europe. And the co-authors here, Jessica Hicks and Carrie James from World Hepatitis Alliance, and Jose Zuniga from IAPAC and the Fast Track Cities Institute. Thank you.
Thank you, Sindhu, and thank you for keeping it right on spot in terms of time. You have managed to save us about 12 minutes for questions, and I just wanted us to have another round of applause for all the presenters, please. Thank you very much. And now we will have a round of questions, and please address your question or your comment to a specific presenter so that we give them an opportunity to answer. I see no hands. Okay.
I have a question to Sindhu. Because Sindhu, can you explain what was the population of men having sex with men? Were it men living with HIV? Were it men at risk of HIV, on PrEP? Can you a little bit tell about it?
Sure, thank you. So it was an online survey. So it really went out to anyone who identified as a man having sex with men over the age of 18. So it's kind of a broad survey.
And do you have information on HIV status?
We did collect data on HIV status as well. That has not been presented here. I'd have to go back and kind of look into the data, but I can definitely do that and get back to you. But we did look into co-infection, including with HIV.
Thank you very much, Sindhu. Any other question?
So it's not actually a question, it's just a comment, because you said something, I'm not going to be able to say it exactly as you said it, but you said that Netherlands, Canada, and Australia were early adapters of harm reduction, and that was really interesting for me, because I'm from Portugal, and we are always seen as a very early adapter of harm reduction, and we aren't. And I feel that we are not, because we only had drug consumption rooms, I don't know, 4 years ago, and drug checking not so long ago. So yeah, we decriminalized drugs, but we stopped there. And there are a lot of more developed countries around the world in harm reduction than us, which makes me sad. But I was happy to see that we were not in those countries, because we usually are, and it's not fair.
Actually, I was pointing to the 3 countries I had data from. So I think I didn't talk about Spain or Germany, because there are more countries where we're early adapters. But those 3 countries that was included in that analysis were early adapters. So yeah, it's difficult always. Some countries say they are early adapters, but have a very low coverage of programs. So I think there's not really a definition of early adapters. Maybe it might be good to define that.
Thank you, thank you. Any last questions? Okay, so with that, I want to say thank you once again for your participation, and thank you once again, all the presenters, and we shall end there for today and have a very good evening.